Dana Childress from the Integrated Training Collaborative. It's noon, so I'm going to get our web discussion rolling. I'm delighted that you're here today to join us for this web discussion about a pretty hot topic. We're going to talk about using a primary service provider approach to service delivery. And we are pretty excited. We're expecting a pretty nice sized crowd on the web discussion today, and we'll have folks, lots of our colleagues here in Virginia, but we're also expecting some folks from other states, which is always exciting to be able to hear about how things are working in other places. So we're happy to have all of you joining us, and I know we'll have people kind of coming on over the next couple minutes. We wanted to let you know that this topic has really come out of requests from you guys. Last September, some of you may have joined us for our first web discussion. We talked about frequency and length of services in early intervention, and from that discussion we had folks asking for more information, another web discussion, and they wanted to talk about how to use a primary service provider approach. So we heard you, and that's what we're launching today. We know it's a pretty hot topic, and we're interested in your experiences, your ideas, how this has worked for you, or what more about what you'd like to know. The web discussion today is a little different than a typical webinar. A web discussion is really designed to get a conversation going online and give you opportunities to learn from each other. This is not the kind of webinar where we're going to do a lecture and tell you how to do something or how to use it. Instead, we're going to talk about the big picture of primary service provider approach in the context of early intervention, and probably most importantly, we're going to have the opportunity to hear from a program that's been working at making the primary service provider approach work for them. So we encourage you to share your questions, share your thoughts, and hopefully you'll learn some really important stuff that you can go back and think about how you could apply it either to your program or maybe to your own practice as an individual provider. So we're happy to have you with us today. So let me introduce the folks on the phone with me. My name is Dana Childress. I'm an early intervention professional development consultant with the Partnership for People with Disabilities. I work on our project, the Integrated Training Collaborative, which is tasked with providing professional development to the early interventionists in Virginia. And I'm really delighted to have Susan Sigler and Tracy Shiplett join me today. I'm going to let each of them introduce themselves. They're going to be the stars of the show. They're going to talk to you later on today about how they're making primary service provider work. So Susan, would you introduce yourself?
Sure, thanks Dana. My name is Susan Sigler. I'm the clinical coordinator for the Infant and Toddler Connection of Fairfax Falls Church, and I'm also a speech therapist. And we've been working on getting this in place for about 2 years, and we're looking forward to sharing that with you.
Okay, thank you, Susan. Tracy.
Hi, my name is Tracy Shiplett, and I'm a practicing physical therapist and clinical supervisor with Therapy for Kids, and we are a contracting therapist with Infant and Toddler Connection of Fairfax and Falls Church.
Okay, well thank you. Welcome, Susan and Tracy. So as we go through today, Tracy and Susan are going to jump in. They're going to share their experience a little bit later. And you guys are welcome to shoot questions and comments to all of us using the chat feature, which is in the lower left-hand corner of your screen. So feel free to use that. And Susan and Tracy and I will do our best to try to answer your questions as we're going along. Okay, I see Amy says we're having a hard time hearing you. Let me pick up my phone instead of on speaker, Amy, and let me know if that works better. Can you hear me any better now, Amy? Yes, Dina says yes. Okay, I'll hold my phone. We'll make it. Oh, good, Amy, you're louder. Not sure if that's a good thing, Amy, but we'll go with it, right? Me being louder. All right. Well, thank you guys for letting me know that. I appreciate it. So let me walk you through our agenda today. We're going to start out by talking about some discipline-specific guidance that's related to using a primary service provider approach. We're going to just kind of get the big picture on what are the professional organizations in our field saying about this approach and how are they supporting it. Then we're going to dig a little deeper. We're going to talk about some characteristics of this approach, and we'll hear from Susan and Tracy about how they're implementing this approach to teaming in their locality. Throughout the webinar, we'll discuss some of your burning questions. We'll throw some questions out to you, and we would love to have you answer them and tell us what you're thinking using the chat and some of our other tools. So to start us off today, we wanted to hear from you how you describe the primary service provider approach. So we were really interested in what words you use or what phrases you use. And I want to invite you to type up here on the screen. So the way you do that is you're going to look to the left of your slide where you see the little notebook on your screen, and you'll have a vertical toolbar to the left. About four boxes down, you're going to see an A, and it probably looks like either an uppercase A or an A with some horizontal lines. You're going to click on that A and then move your cursor over to the screen. And once you'll click there, it'll create a text box, and you can actually type your answer right on the screen. So I want you to try to do it that way, so what people are, how people are describing this approach to families and maybe to new providers, etc. I see some folks are already starting out. If you have any trouble getting your text box to work on screen, don't worry about it. You can type into chat too. Jeannie, who is our technical specialist, will be moving the boxes around a little bit in a minute so that we can read everybody's information. So I'm going to pause to give you a chance to write. And I see some folks are writing more than a couple of lines. Don't worry about that. Your box will expand, and then we can actually expand it once you're done so that we'll be able to read everything you wrote. All right, well, we keep typing. You guys are doing an awesome job. It's nice to see all this popping up, and it's very normal that stuff overlaps. It happens all the time. So those of you who aren't typing, as people are writing, I want you to take a chance, try to read what's popping up on the screen, and I want you to look for themes or common words. And as you see those common words popping up, type them into chat. So you might see, like I'm seeing primary provider, I'm seeing one person. Type into chat some of the common themes or words you are seeing from what people are putting on screen. Yeah, Dana puts team. ITC of Norfolk sees consulting, yep. One provider. Yeah, I definitely see one provider. I see working together. That teaming concept is really important. Consistent family priorities, yep. MM writes one person, one provider. And what a lot of people are writing is one provider who's consulting with other providers. And that team idea is going to be really, really important as we walk through things today. Yeah, I love the one up in the upper left-hand corner. It uses the expertise of team members in a more coordinated way. That is beautifully said, because that really gets at the heart of what we're going to talk about today. Yeah, Fairfax, one provider team, one person who works with the team. Yep, that coordination piece. And Stephanie, right, colleagues, team supporting one another. So absolutely, so all the great words you've put on here really kind of boil down to that one provider who's kind of a liaison or support to the family, but definitely with support. One of the myths of a primary service provider approach is that you're kind of a lone wolf. And when you're really doing this right, that's very far from the truth, because you've got lots of support. And you've actually got access to a team who can help you, and the family does too, so it's a wonderful thing. So Diane writes, requires infrastructure to allow for collaboration, communication, and planning. Absolutely, and we're going to hear from Susan about how they've put some of that into place. You'll get an example of that today. So here's the definition that is frequently cited in the literature for a primary service provider approach. I'm actually going to read it because we often have people joining our webinars who don't have video access, so they're only listening. So the primary service provider approach to teaming is a family-centered process for supporting families of young children with disabilities, in which one member of an identified multidisciplinary team is selected as the PSP, who receives coaching from other team members and uses coaching as the key intervention strategy to build the capacity of parents and other providers to use everyday learning opportunities to promote development. So similar to what you all just said is that we're talking again about team, and we're talking about the person receives coaching and support from other team members, but also uses it as a strategy to support the team. So it's a real give and take process. Okay, so Emma says, very curious as to the source of the team. There's no team in situations I often encounter. So type a little bit more in there about that, because the team idea is really, really important if you're going to be, if everybody's going to be comfortably supported using a primary service provider approach. So that's an interesting reflection there. So if we dig a little deeper, we're going to, when you're thinking about a primary service provider approach and even tackling this, you want to know what resources are out there. So here we wanted to show you one resource that's out there that's really being used a lot in our field. And this is a resource that Susan will talk a little bit more about because it's one that they used in their locality. We're not teaching you the primary service provider approach from this book. We just wanted you to know that it was out there for those of you that might be new to this approach or trying to adopt it, that this is one of the many resources that are out there. The nice thing about this resource is it really hones in on early intervention, which is what, as you guys know, we don't often have. We often have practices that really folks are thinking about for school age or for classroom based, but this gives you some guidance there. So when we think about the primary service provider approach, it really aligns nicely with our field's recommended practices. And when we think about where we get those practices, right now there's certainly we've got some great work in our field that's been done that really has become quite widely accepted. And so here on screen we have a screenshot of the document, the mission and key principles for providing early intervention services in natural environments. Everything we do in early intervention, regardless of what approach we're using, should wrap back around to the mission and key principles of early intervention. I'm going to make an assumption that many of you are familiar with this document, so I'm not going to walk through it necessarily with you, but I want to key in on the fact that, as you can see here, you sort of can see, you probably know the mission really focuses on our role as providers to assist family members in enhancing the child's development. And then if we look down here at Principle 6, we're going to look a little closer at that because that principle really narrows in on the primary provider. So key principle 6 really tells us that the family's priorities and needs and interests are addressed most appropriately, again, by that primary provider. And the next couple line I think is so important, who represents and receives team support and community support. And so I really like the idea of the primary provider as a representative of the team. So that reminds us about the importance of the team. So we're representing the team but also receiving that support. So when we look at that, when we look at this key principle, it really encourages us to think about the concept of team broadly and thinking about service providers. Okay, I heard a little music. There we go. But service providers is only one part of the team. The team certainly encompasses that family again too. Good teaming practices are integral, and like you guys said in your statements earlier, we're talking about one key consistent person who is that contact, who gets to know the family really well, but that person is not alone because that person is supported by a team of professionals who share their expertise to help the family, support the family throughout their early intervention journey. So the PSP approach really emphasizes role release, and that's not always easy for folks on teams. Role release is really important because it's how we share our expertise with others. It's all about teaching others how to implement early intervention strategies. So when we're doing it right and we're meeting that mission, we can use a primary service provider approach to share our expertise across our team members. We're going to look at the American Physical Therapy Association fact sheet today, but when I was reviewing it, one of the things they write about role release I thought could apply to all disciplines. They talk about when you're using a role release and you're using a primary service provider approach, you can teach others activities and intervention strategies that they can use when you're not there, that they don't require your direct expertise. That means you're teaching them intervention strategies. It doesn't mean you're teaching them to provide physical therapy or developmental services or speech therapy. It's all about how we share our expertise. And as they say in that document, I think this statement can also apply for all of us. Using a primary service provider approach can be both ethical and legal and exist within our scopes of practice. Okay, I see something has popped up in here. I'm going to just read that. So says she works in several states. One state where their primary provider is always the special instructor who will, if pressured, ask for a therapy consult, but not always. So it sounds like that state isn't really using a primary provider approach maybe. If they don't have that team support. Or other situations I'm trying to read through in which the primary provider is the sole provider and there's no access to other disciplines. So yeah, that sounds like there's a primary provider. It's almost like there's a provider. If they don't have a team or access to that team, then it's really probably not a primary provider approach. Wouldn't you agree, Susan, since that team is so important?
Yeah, we will talk about a couple of those things, but the reason you keep seeing the word team is because you can't use this approach without having a team. So One of the things we'll talk about in a few minutes is what really characterizes a primary provider approach so that we're all using the same language and having that shared meaning. But for example, if it's always one discipline, then you're not using the approach. A key to this is that every discipline needs to be available to be the primary provider when it's the most appropriate.
Yeah, thank you. That's a great point. I think Corey raises a good point that there's confusion about. I think primary service provider has become sort of a broad term that we use pretty loosely. That okay, well, I'm using a primary provider approach, but today we're going to kind of drill down about what that really means. So I challenge you guys, just like our participant here is doing, trying to think about, am I using the approach as it's intended? And that's what we're going to walk through today. So there's lots of myths, and I think we're actually started, we've already, these comments were kind of working us into this real naturally. There's some different myths about using a primary service provider approach that I know I've certainly heard many times, and you guys probably have too. So I want you to read through these myths, and you're going to use your pointer tool to drop a pointer on the myth that you've heard most often where you are. Or maybe it's one that's a real burning question for you. So the way you access your pointer tools, or you go to your vertical toolbar to the left of your slide, the second box down, you're going to see a little starburst, or it might have a little hand or a check mark. Click on that box. If you click in the lower corner of it, you'll open up an extended arm. You can pick up your pointer by clicking on it and then move over to the slide and drop a pointer. You can only drop one. Drop it on the myth that you hear most often. And we'll start with that. We're going to walk through all of them, but I want to see which ones really have some meaning to you guys. These might not be myths you believe, but they're ones you've heard before. All right, good. We see some popping in. I'll give you a little bit of time. All right, yeah, I see folks almost like moving theirs because you're right, it's easy that you probably have heard lots of these. Let's see. I think it's hard to tell where to start because you guys are doing such a great job dropping these. I'm actually going to start, it looks like we've got a lot of them on number 1 here. So I'm going to start at, whoops, one just jumped off of number 1. I'm going to start with number 1. So the primary service provider is determined according to the child's area of delay. This is an interesting one because we could take primary service provider out, and this is a myth for services and early intervention in general. We definitely don't determine services based on the child's area of delay. Services are driven by the outcomes in the IFSP. So regardless of what approach you're using, we should be determining services after outcomes are written, and then we're going to determine the provider who has the knowledge and experience, expertise that best matches what's needed to help the family address the outcomes on the plan. So that's a different way of looking at, so for instance, if a child has maybe qualified due to some concerns with feeding and communication, we don't know necessarily, it doesn't necessarily have to be that the speech pathologist is the person for that child. We're going to look at the team and see who on our team has the necessary expertise to support that child. On some teams it could be the educator, some teams it could be the OT. It's going to depend on the team member's expertise and the match between the outcomes and the provider, not so much the area of delay. Okay, so if we take another one, let's look at this last one, number 5 here. This one, I see a lot of folks write this, and that's actually going to be a nice segue into the next couple of slides we'll look at, where I can't use the PSP approach because it conflicts with my license requirements. In fact, we're going to walk through the little blurbs from each of the professional organizations to help folks who are a little worried about that see that the professional organizations in our field really do support this type of an approach. And I think that one really gets to some of the other ones that we have here, where the PSP has to be all-knowing, kids who have a primary service provider receive less therapy, or a child can only have one provider. All of these are definitely myths. As Susan said, when you're using the primary service provider approach, it's intended to be a way to efficiently and collaboratively support families. So the primary service provider is not supposed to be all-knowing, get support from your team members. I mean, really all early interventionists should be generalists and have good information about early intervention strategies and development across all areas. We all have our areas of expertise, and that's how we access those areas of expertise to support families across our team. Kids don't necessarily get less therapy just because they're in the primary service provider approach. In fact, the benefit is they might have one person who liaisons with the team, one provider who gets to know them really, really well, but they have access to the expertise across the team. So it can, there's some research that tells us that having lots of providers in a home can be detrimental to families' quality of life. It can be stressful to families and confusing when they're getting information from multiple providers about how to do things and change their day and tweak their routines. So one person to sort of coordinate that information can really improve things for families. And then number 4 here, definitely this approach is not saying we have one service provider. We're still making individualized service decisions. We're just going to identify the provider who's going to be that primary contact for families. Susan and Tracy, do you all have anything you want to add to address any of these myths that maybe you heard in your systems or you've walked through?
I think what we'll see is when we get to the real characteristics of it, it'll kind of pop these myths right out of our head, I hope. As I look at where people were voting, I think we're going to really address each one of them as we really talk about, to truly be using the approach, what the characteristics are you have to have in your program and in yourself as an individual.
Okay, all right, great. Yeah, I think we kind of can't emphasize that team aspect enough. So let's see, let's take that jump off of number 5, that 5th myth there, and actually see what do the professional organizations have to say. So I thought we would start with the American Physical Therapy Association, because I've often heard our PTs stress about this, that this goes against my license, or I really can't share my strategies, or I can't turn other people into physical therapists. And we want to make sure that folks on the call are rested assured that that's not what any of this is suggesting. And in fact, APTA has kind of taken the lead on putting together a fact sheet on using this approach to teaming. This fact sheet is a really good resource, and I'd encourage you to pull it up if you're interested. The handout that you got with the webinar today gives you a direct link so you can access it. But I've pulled out one statement out of this. Oh, thank you, Jeannie. Jeannie put that handout right in, or the link to the handout in case you didn't see that when you got your registration information. So if you look at the APTA, they really describe the primary service provider as a primary liaison between the family and other team members. And I love that idea of a primary liaison. It sort of emphasizes that this person is a connection to the rest of the team. So you're not really doing this approach if you don't have the rest of the team. So this is a liaison between family and other team members. This person receives consultation from other team members and uses coaching and other strategies to interact with and teach other team members how to support the families. And again, I love the idea as they emphasize that this is not, we're not talking about teaming to reduce services or to turn others into therapists or educators. It's just a way of sharing your expertise. And it really, primary team service provider teaming emphasizes communication, collaboration, and that cross-disciplinary boundary role release. One of the things I know Susan will talk about is in order to make this work, it's essential that team members have planned times to meet at regular intervals to discuss their care plans. And that was emphasized in the APTA fact sheet, and you're going to hear more about that in a little bit. So similarly, if we look at what the American Occupational Therapy Association told us, they have a practice advisory on the primary provider approach as well. They indicate that OTs are ideally suited to function as primary service providers, and they should receive team consultation and support. So again, we've kind of seen a theme here. Now when we look at the American Speech and Hearing Association, ASHA, I couldn't find a document that zeroes in on primary service provider approach in the ways that the PT and OT associations did, and I have asked some speech pathology colleagues, and they pointed me here. So the core knowledge and skills for EI practice, they call out some information that really aligns well though. They talk about the continuum of service delivery models, the collaborative design of intervention strategies, and speech pathologists being members of a team. They talk about implementing strategies as team members and teaching families, caregivers, and other professionals specific intervention strategies as appropriate. So again, that collaboration across teams is really, really interesting and really emphasized. I see a comment in here that's curious about how many webinar participants are primarily working in very rural settings. I'm sure we have a combination. So folks, if you want to reply into chat and let her know if you're working in really rural settings. I know certainly across Virginia we have a mix of settings, and how you implement this approach is going to depend, what it'll look like will depend on how your team works, certainly. So that's a great point. I don't know for you guys, Susan and Tracy, you're primarily in more of an urban setting, right? Do you have some more rural areas up where you are that are using this approach?
I wouldn't say that we have rural, but I think some of the strategies we use might work in a rural area.
Okay.
And particularly videos and pictures, and we'll talk more about that.
Okay. All right, great. So it looks like in our chat we have somebody, Julie says she's in Ohio. She serves a rural area. Kelly says 75% rural settings. So as you guys are thinking about that, you know, like Susan said, we're going to give you some strategies that we hope you can think about and adapt regardless of whether you've got a lot at long distance and you've got, you know, to travel to see families, you've got a big team or a small team. I think there's some strategies out there for you to consider. I see we have a question from Kathy. What about deciding on a provider when billing insurance is important to the family? Kathy, I'm going to, if you don't mind, I'm going to hold off on your question. Let's make sure we revisit it. We're going to talk about some more specific strategies a little later. So we'll try to get to that idea of thinking about billing. I don't think that you're going to change how this works based on billing, since we don't make service decisions based on funding sources. But we'll try to capture that a little later. It's a good question though. Thanks, Kathy. So to get back to our practices, the last one I wanted to call out is the DEC, the Division for Early Childhood Recommended Practices. And this is really, the DEC is part of the Council of Exceptional Children. It's thought of as sort of an educational organization, but the Division for Early Childhood's goal is to have practices across the field of early intervention and early childhood special education, early childhood. So these practices really can speak to all of us. And the DEC Recommended Practices has a teaming section, and in fact, practice number 5 really emphasizes that primary liaison. So they talk about one practitioner from the team who serves as that primary liaison between the team and the family. And determining that primary liaison is based on the child and family priorities and needs. So as you can see, the idea, sort of the broad idea of a primary service provider approach really aligns well with the guidance in our field, not just the big picture recommended practices, but also the information from our professional organizations. So I think you can rest assured that when this is organized well and you have the support of a team, being a primary service provider will not jeopardize your professional expertise or training or license. So now we're going to dig a little bit deeper into key characteristics, and I'm going to ask Susan to walk through some real specific characteristics of the primary service provider approach.
Great, thanks Dana. And I hope as I do this I can address some of the questions that have been coming up in chat. We'll either try to address them here while we discuss key characteristics, or just a little bit later when we talk about some of the implementation strategies we took to help us move a little bit forward. And the first one I want to talk about a little bit is that, yes, one staff member must be designated as the primary provider, even if multiple providers are involved. So even taking a step back and saying the idea that there's always one provider, or the myth, let's say the myth of the child can only have one service provider, that truly is a myth. The key is that you know who the primary provider is for that child and family. So many of our kids have more than one provider, but we still consider that that child is receiving a primary provider approach to intervention and to teaming. Another idea we have around this is that the primary service provider should change as infrequently as possible. And the reason for that is, if you look at the reason why we work at using a primary service provider, is that we really are looking at maximizing the relationship with the family, so that it's important when possible to keep that person as consistent as possible. So we talked a little bit that you might have more than one provider in there, so it's going to be important that when you do, that you have joint visits that occur with those other team members. And the reason for that is part of the joint visit is to provide support to the family, but also to provide support to that primary provider so that they can help the family learn how to use those strategies in their everyday routine. So if the primary provider really is the one who's most in touch with the family's priorities, their concerns, their day-to-day activities, they can take that information from another discipline and figure out how to help the family implement that along with the things they've already been working on. Okay, I'm going to go back and address MM's concern here specifically. And one of the main characteristics of a primary service provider approach is that teams and team members should be clearly defined. And this is really important for the provider as well for the family, maybe even more important for the provider. Because if you're working in a system where you have a sole provider or that only one discipline can be that primary provider, you're not using this approach. You must have a team that consists of all of the different specialty areas so you know who to go to ask if you need some additional support. Let's see. Each team member, I kind of alluded to this, but I want to make sure to say it again, that each team must include in each type, a PT, an OT, an educator, a speech therapist, and a service coordinator. Now typically when you read about the primary provider approach, some of the more specialized practitioners will be on more than one team. So for example, your teachers of the hearing impaired, your vision specialists, maybe your mental health professionals, your nutritionists, they may not be on just one team. But you need to have at least one PT, OT, educator, speech, and service coordinator to make a real team. Otherwise, the family is not receiving this approach to intervention. And I also want to talk back to the question that Kathy had about insurance in this next point that I want to make about a characteristic. Every therapist and educator on the team should be available to serve as primary. So one of the myths was that the PSP is determined according to the child's area of delay, and Dana did a great job of pointing out that we don't decide who the provider is going to be until after we've written the outcomes. And to get the information to write the outcomes, we've been talking to the family about their priorities and their concerns and their supports. And one of their supports is their insurance. And in Virginia, we do bill insurance, so it's something we need to think about. So if it might be better for a family to have a provider and it is clinically appropriate that they can bill insurance for, then we might make that choice of provider based on that information. That's all part of the information that goes into making a decision about who becomes that primary provider. But that's why it's really important that all of the providers are available to serve as primary when it's important for a family or a priority for the family.
So Susan, we have a question in here you've probably seen about. It's a great question. Many providers, many programs using contractors so they don't have an in-house team. So any recommendations, and maybe we'll talk about this later, but how they get together. I know that one of the recommendations that I've read and thought about is, folks don't, ideally it's wonderful when people can get together face-to-face, but teams can get together and consult each other in different ways. If they need to do that at a distance by phone or something, I think a local program would really need to put something in place to make sure that happened, whether it was face-to-face or by phone. I don't know if you have recommendations for that question, Susan.
I do, and we're going to talk a little bit about how we did that from a contracting point of view here, which is a down-the-road suggestion. But yes, there are many other ways to team other than being a dedicated team. And I think what I've noticed in some of the localities that use contractors is some of these natural teams start to pop up on their own. And when I've talked with other regional local system managers, they've been able to sort of identify. One of the strategies you can use is going back and looking at the kids on your caseload and kind of saying, who do I often talk to about this child? And you kind of figure out who your own team is. You may not work together, but if you're starting to change your mindset a little bit about knowing who you would go to talk to, you're moving down the road. And we know this is just, it's a work in progress, regardless of whether you're starting from scratch. The idea is if you feel like you're a lone wolf, you need to start figuring out who your team is.
Yeah, I think that's a great point. That's the key right there, is finding who your supports are. Chesapeake has a question. Can the service coordinator be the primary provider?
We are using, Dana showed you the book specifically, the book that we're using, which is the Sheldon Rush book, which I use to help us move forward. And in that, the service coordinator is not designated as a primary provider. And the reason for that is the service coordinator has a very specific role, and they're very important. What I would say is the primary provider is the one who is doing the most liaisoning with the service coordinator to let that service coordinator know what the child and the family need.
Okay. Now in Chesapeake, having worked there, I mean, I don't know if the service coordinator is also a provider. So like when I worked there, I was a service coordinator and an educator. That would be different because in my role as an educator, I might be the primary provider. But if the service coordinator is a dedicated service coordinator, meaning that that person's only role is service coordination, it sounds like the recommendation is that the service coordinator has a different role than the primary service provider.
Correct. Just as when you have blended service coordination and you're a provider, you know when you're wearing which hat. Sometimes it's called blended for a reason. Sometimes it's not so clear. But it would be the same as when you're acting as the primary service provider. It would look a little different from what you're doing as the primary service provider.
Yes, so we have a comment from Norfolk that they would love some ideas about encouraging providers to how to help them get more comfortable with addressing developmental areas that might not necessarily fall under their discipline, other than defaulting to just bringing in another person, another assessment, or another person. And don't know if you want to tackle that one now, Susan, or wait until we talk a little more specifically about how things are set up in your system.
I think when we talk a little bit later, it would probably be better if we get through these and see where everybody is. But I am going to have Tracy address that a bit later because she is not only a provider, so she's doing this as a provider, she's also working to support a group of almost 30 providers in doing just that.
Oh, good. Okay, great. So Norfolk, we'll hold on that one, and we will definitely address that one later. Okay, so good. Looks like Kathy says teaming in the office works for you. Good. There's a question from Southwest says, if you're the primary provider on the team, you probably should not be the service coordinator as well, right? I don't know that we're saying that. I don't know, Susan, what you would recommend there.
You know, I don't know that I'm the best to answer that. I would refer back to the book where they talk about that specifically because in our locality we don't have anybody who is wearing both hats at the same time with the family. So I think there are some probably localities who are doing that. Maybe if you want to put that in chat, if you are trying to move to a primary service provider approach and you have blended service coordination, maybe you'd want to give some hints of how that works. I know Robin's commented here that we have to be careful of boundaries. So Robin, maybe if you wanted to just add in chat a little bit some of the things you've done to kind of help with that.
Yeah, absolutely. It's a great question. So let me get a sense of where you are now. So based on what Susan has talked you through, think about, do you think your program is using a true primary service provider approach based on the characteristics Susan just walked you through? So we're going to take a poll and see how you feel like you're doing. The way your poll works is you're going to go to the left of your slide in the participant box where you're going to see your name or the name you signed in with. Below your name, there's a series of 4 boxes. The 4th box over, if you hover your cursor over that, you'll get a drop-down menu and you can make your choice. Pick A, B, C, or D. Click on that to make your choice. To say whether you think you're using it with all families, using it sometimes, no, we're not really using it, or you're still not sure. So go ahead and make your choice, and after those come in, looks like people are doing that. We'll publish the poll on screen and you can see how everybody did. I see some folks are using their pointers, and that's another way to do it too. Looks like we have the pointers as showing some variety there. I'm going to wait another couple seconds to let people post their votes. Looks like it's slowed down, Jeannie. Would you go ahead and post for me? Okay, so it looks like we have, similar to what we see on the screen, a combination. So on the screen, when I look at the pointers, we have a few more in the no, not really, but a couple people spread out. When we look at our poll results, we have using it sometimes. It seems to be the majority of folks. Sometimes or no, not really. And that's okay. This is a great place for you to be getting online to learn and think about it. I think a lot of people are at where you guys are. A lot of people are feeling like we're trying to put it into place, but like somebody said earlier on, you've kind of got to have the infrastructure to build your team process to get it in place. So we hope you'll get some ideas to help you move closer to A, where you use it all the time. Okay, so let's think about the strengths. So I want you to use chat this time. Oh, that's funny. Susan and Tracy typed in and said they wouldn't even answer A, and they've been trying to use it for 2 years, so it's definitely a process. So type into chat, what are some of the strengths you think of using a primary service provider approach? And this is whether you're doing it now or you just are learning about it. What do you think some of those strengths might be? You could think strengths for families, strengths for the provider who is working in this approach, or even bigger picture strengths for the program. Type into chat using your chat box, which you guys are great at. What are some of the strengths of this approach? Okay, Ashley says less people coming into the home and making tons of suggestions. Definitely more of a coordinated approach. Expertise, learning from colleagues, like Corey said, yeah, learning from your colleagues is a great thing. Barb's is a stronger bond. Building relationships, definitely. Streamlines information. I like that. And services for families. Yep. Opportunities for providers to expand their knowledge and expertise. Yeah, there's a lot of benefits to this for sure, and there's a lot of benefits for each group here. Let's see if we have any more. Single point of contact for families. Yeah, that's always going to make it easier for families. So Nikki writes, stronger relationship with families ensures that they truly share their priorities so they're more comfortable. Yeah. More natural. The parade of therapists in and out of the home. Yeah, we could get away from that. You know, many of you know, I've said this before, my son had early intervention for a little while, and I only had a physical therapist coming every other week or so. But you better believe that day she was coming, my life worked around that. And I did vacuum, which I always told families, you don't have to vacuum when I come. I did. It's, you know, it's just a stress that's in addition to families' lives, so this approach can hopefully try to avoid overwhelming families for sure. Shelby says allows professionals to teach each other, certainly. Well, let's think about the challenges, because this is often where people go first. When you think about the challenges that could be faced by at the program level, the provider level, or the family level, what are some of the challenges you might think about? And I think Norfolk mentioned that here with getting folks who aren't maybe comfortable working in that role, crossing disciplines, crossing developmental domains, helping support your staff to where they're comfortable working as a team that way could certainly be one. What are some other challenges you could anticipate? Okay, so Julie writes, coaching in a team setting, not just with the person you want information from. Yeah, just sort of coordinating, sometimes even coordinating schedules with a team setting can be a challenge. Challenging for beginning therapists, certainly. Some providers have worked, yeah, Jenny writes, working outside of their scope of practice. So we encourage folks, you know, especially if you're a leader, if you can share some of those the professional guidance from the associations, sometimes that can help folks to see that this has already been addressed and thought about. Meeting the teams regularly. Challenges could be on time and billing with coordinating that, coordinating joint visits, having parents wait while you consult with someone. So there's certainly lots of challenges out there, but Susan and Tracy are going to talk you through some of the ways they've tackled those among their folks. Fairfax says some families aren't buying into it. They've heard different recommendations from doctors. Yeah, and billing certainly. So there's certainly lots of challenges, and so one of the ways we wanted to help you address challenges and think about them today is hearing from a program that's been working through some of those. So that's where we're going to go next, Susan. We are going to jump to implementation of the primary approach, because I want to make sure we have plenty of time for you and Tracy to share your experiences. So if you guys want to just sort of talk about how you've set it up in your program, what's worked well for you, and I'm hoping we'll address some of those challenges as folks are hearing what you guys have put in place.
Okay, I'm actually going to back up to one of the challenges that came up, and I'm going to have Tracy address that specifically because I saw several people comment on the how difficult this can be for new therapists, new teachers, young therapists, that sort of thing. So I'm going to let Tracy talk a little bit about how she's approached that both as a provider and then as an agency leader with her own staff.
Okay, great.
Hi. So as a provider, I think looking at beginning providers in early intervention is always a challenge because we're expecting people to still know their knowledge in their own area. For example, as a physical therapist, we're saying you need to know all of these physical therapy skills, and then we're throwing at, hey, now you need to be able to help them with language, we have to help them with communication, we have to help them with everything. And I think one big key we found is our beginning therapists need a lot more support, and they need us to be mentoring them and guiding them not only in their own discipline but with other disciplines. We do a lot of video teaching. I have people shoot videos on a regular basis and really are having people come back and forth. And some of those younger therapists are going to need more support, whether it's something officially on the IFSP plan or whether it's something that we're collaborating together and just mentoring and supporting that therapist as they go through things. Does that help?
So that's great. So it sounds like you've got some things in place to support your new therapists or folks coming into your agency to give them time to understand and see how these practices are used. So I think that's great. It sounds like you've got some things in place.
Yeah, and I'm gonna address that as we talk about how we went to changing toward this, because one of the things we realized was that not everybody is equipped to be the same exact primary service provider. And so when I talked before about everybody needing to be available, we need to have people in the system who understand the strengths of each individual and not just group them by their discipline. And that's a challenge. I mean, a lot of times you recommend a service based on the discipline where you might say speech because the child has a feeding concern, but you know what? The OT who lives down the block is actually much better at addressing that concern. So I think you have to be looking at that really big picture. There have been some sad comments over there in chat I just want to address real quickly. Kristen says that UVA outpatient therapists and physicians have a feeling that EI is no longer a viable option due to this model with the coaching interaction style. And a lot of that has to do with those myths that are there, and I will say we are not finding that with our doctors and outpatient clinics here because we use that team. So many of our families do receive more than one provider. If I let you walk away with one thing today, I want you to, and I'll give you some numbers on that later, that it does not mean that it's a sole provider out there who's in over their head. And then Diane talked about, what about a student with complex communication needs whose family may not interact with a speech person? Well, we would never have that happen, because if the speech was the most appropriate person, then the speech would be the primary service provider assigned. So I hope that helps.
Yeah, I was thinking about that too, Susan. You know, I think about as an educator, I would not have been the person who would have been chosen as a primary service provider if a child had feeding issues, for instance. I mean, that just, I can monitor strategies and do some basic feeding work, but if a child had complex feeding issues, for example, I'm not the best person, so we would look to another team member. So we encourage folks to, you know, like you said, step out of disciplines, figure out who's the best person, and that's who your primary will be, not automatically one or the other because of billing or because of who lives closest to the family. You know, we're really going to hone in on who's best qualified to support that family.
Okay, so let me jump in with some of the things we did. I want to make sure we have enough time to sort of talk through those things, and I hope it'll address some of the other comments I'm seeing over in chat, and if not, maybe we just need to have another webinar, and we're happy to do that too. I would say that one of the things that we did locally, and I'm just going to touch on these briefly. The first that we did is why Tracy is sitting here with me today, is that we made sure that our contracts with vendors required a team of all 4 disciplines, and that each vendor agency had regularly scheduled team meetings. So we did not have providers out there who were working independently who felt like they didn't know who their team would be. We did that through contracting. Our contracts also allow for training. So we did a 90-minute training to all the service coordinators and direct staff about the principles of the primary service provider approach before we ever tried to move towards it, so that we could put some of those myths to rest, or at least address them directly. And then we did some activities outside. One of the things we did, and we're working closely with the Part C office, is that we changed the way services were written on the IFSP. We have moved towards using some unusual frequencies where the second provider may go in and provide services for example, 6 times during a 6-month period instead of saying monthly or twice a month or twice a week or once a week, something like that. The reason for that being that the primary provider then could be the trigger as to when she and the family needed the support of that second person. So let me give you an example. If speech is a primary concern for a 2-year-old with Down syndrome that we've been working with, but they're getting some new orthotics and we're not sure how that would work, we might add the physical therapist to the plan with an unusual frequency so that maybe they could come out in a burst of service and come twice in a week while we're trying to adapt to using the new orthotics or something like that. We also focused on documentation at all stages through the process. So some of you have written some great things about how you team the office or you know who to call, but we make sure that that is always done and well documented in the chart so that everybody knows what that means. Just to give you some numbers about how this looks in Fairfax, and then I'm going to let Tracy talk a little bit about how her team meetings look. Just to give you an example, over a random 4-week period, we had 133 new children come in and have new IFSPs written in our system. Of those 133 children, 7% were recommended to have more than one service. So about 95% of the kids got one provider at that initial ASP. But we recognize that the initial ASP, we really don't know the family as well as we could. So what happens for our ongoing services, in that same period of time, about 15% of the kids were receiving services from more than one provider. So that IFSP is flexible and the document can change. And a lot of that happens through teaming and support to each individual provider, which I'm going to let Tracy talk a little bit about what her team meetings look like that allow her providers to be able to use this approach.
So we have several different team meetings a month, and as Susan said, we have 26 providers working OT, PT, speech, and educators. And we have a variety of different teaming meetings. We have one large group teaming meeting where everybody is present and we do a lot of videos. So in those situations, a lot of our other therapists are able to learn. For example, if a speech therapist has a video of a child that they have some motor concerns with, then every speech therapist on our team learns by watching this video of this particular child, and often that turns into a discussion of 10 other children with the same similar type issues. We also have smaller group meetings. We change them a lot. We have small coffees with our staff where just an OT, PT, speech, and educator will get together. We also have more regionalized smaller meetings, and we invite the service coordinators to be part of these meetings with our teams. Additionally, our staff does a ton of informal teaming. So we get a lot of videos shared, a lot of text messages, a lot of phone calls. So I think a lot of this could be done in rural situations and a lot of the similar ways that it's done in person. Because in many of these situations, most of the information is being gathered by the videos. A couple people have been asking questions related to how the consults are documented and how they're part of IFSPs. So many times in our teaming meetings, the decision is made that an actual, so for example, if a physical therapist is seeing a child, that a speech therapist actually should come take a look at this child. In some cases, we consider that a mentor visit, where it's not actually added to the IFSP, but that therapist needs some more growth. So that person actually comes out to support that therapist in the home. And in some cases, that isn't ongoing, as you asked before. I know ITC SW asked. In some cases, that actual service is added to the plan as a low frequency. So it's actually added as speech therapy 6 times a year. Could be added from that perspective. As far as permissions for videos, we make the videos with our personal equipment. So most people are doing those. All of our staff have actually tablets that they do their visits with, and they actually record them on their tablets so they can share that with. And that we have individual consent forms for the videos. Does that answer that?
Great, thanks Tracy. And really it's so helpful for me to have Tracy as part of this because her staff are out there doing this every day with the children that are coming into our system. She touched on something about mentor visits versus adding a service to the plan, and I want to be clear about how we're using that locally. And again, this is just the local way we've looked at this is it goes back to the question that's been asked about young providers. I have some speech therapists who have been doing this for so long and know so much about sensory that they might not need the support that someone else needs to learn, that's still learning something new. So as a system director or a program manager like Tracy is, or a clinical director, you're listening to what the person is asking. If the provider is going out to support the therapist, that means they're not addressing a specific goal on the plan, but they're going to provide support to the therapist. That's something they do as a mentor session. But if it's a new concern of the family and of the team, then we add it as a service to the plan.
All right, thanks, Susan. I know we've got questions coming fast and furious. Are you ready? We could move into the suggestions for systems and teams and see if we address maybe some of the questions popped in there too.
Let's go ahead and do that just based on time, and then if we can, then maybe Dana, you can help me with some of the questions and we can just try to answer those specifically. Sure. So one of the things we've looked at for local systems and teams to kind of try, first of all, I would say for anybody today, again, this is just a discussion. It's to get your thinking cap on and to think about why we want to move towards that. One of the things we didn't talk about today is why the primary provider approach to services is truly better for families and how evidence supports that. And there is information about that in the book that we used as a reference. And there's lots of other stuff out there as well, but I do want to say that. And that's something to make sure you start with your feet on the ground about why you're doing it, because this is not it should not be put in place as a way to provide less services or to save money. Because I will tell you it does neither. The services are typically the same frequency as we were using before, maybe a little bit less as we've moved along, but in the beginning certainly. And the support you need outside of direct service is going to cost you more as a system. So to make a commitment to doing this means that you're doing the whole thing, which means providing support for the teaming as well. So some of the suggestions we've had and we've thrown out there is that one of the things that teams, formal teams, can fall into doing is that they tend to team the kids that they share. So you often hear in team meetings where a team will talk about the kid who gets PT and speech, and the PT and the speech therapist will talk in the team meeting. And what we found was that those kids are really being teamed informally. The kids that should be coming up in true teaming meetings are the new children, because those are the children that you need to introduce to the rest of your team so they know who they are. Sometimes our teams bring a picture on their phone and introduce the child that way. They talk about the goals. They talk about what their challenges are already, and they try to identify where they might need support for their team in the future. We have one team who made a brochure with the pictures of all of their providers on it so they could actually show it to the family. So if Tracy went out and said, "Hi, I'm Tracy, your physical therapist," she'd have that brochure to show them. And when I talk about, I'm going to go back and talk to my team, this is who I mean. We make sure that all of the kids get teamed, and one of the things we did in the very beginning was we took all the kids who were getting more than one provider and we sat down and talked with those providers and said, if you had to choose now who is the primary provider, who do you think it is? And I want to talk just a little, we're almost out of time. I just want to say something real quickly about that and make sure that we touch on that today. There are so many reasons why someone might be identified as the primary provider. And as long as we're sure that one of them isn't just availability of staff, we shouldn't have that one. But I have found people fall into the role of the primary provider for different reasons. It can be based on the family's need. Sometimes it's that they speak the same language. Or their availability of their time to be able to work in that family's routines, or they might be the right communication style or match for a family. I'm going to let Tracy tell a little story about a family that actually was getting 2 services, and at the ASP we had identified which one we thought was primary, and she's going to tell you a little bit what happened after the team went out to see the family.
So this particular child, as we said, was recommended for 2 services. They were actually recommended for education services twice a month and occupational therapy 4 times a month. So as we said, more than one service. With the educator being the primary therapist coming out there, the team went into the home and they were actually doing a regularly scheduled 1 time a month co-visit or joint visit and then the other visit the OT was by herself, and then the educator was there for her other 3 visits by herself. And what they found is that the family actually had a better relationship with the occupational therapist than they did with the educator. And so what we stepped back with and said, well, where do we change? And so what ended up happening is the child's services are changing from that perspective. So the occupational therapist is becoming the primary provider because this family has a bond with that occupational therapist. And then the decisions being made on why still have education. Does this family need education? What is it that the occupational therapist can't cover? And if there isn't something that the occupational therapist does not feel covering, then it may end up that this child actually gets less services, but this family is actually much more comfortable and happier with the way the services are working.
Okay, Dana, I know we're almost out of time.
We are, but I hate to interrupt you guys. It's such good information. I don't know. I know it's right at 1 o'clock. Thank you for that story, Tracy. Those kind of stories really help you kind of put this into context. So I appreciate that. It's 1 o'clock, so I'm going to give Susan and Tracy an opportunity to just wrap up if they have any other parting shots, and then we will take questions. If anybody wants to stay on for a minute or 2 longer, we'll go over a few more minutes just to make sure we give folks an opportunity to ask their questions. So Tracy and Susan, any other techniques or tips you wanted to get, or we can jump right into questions?
Okay, the only one thing I want to say is that know that it's a process and that it's not something that you start doing, and every system has their own little bugs about the way they contract or whether they're rural or urban, and none of those would preclude you from trying to move towards this approach. Tracy?
I think the only thing just to remember, as I know somebody from ITC Norfolk said earlier, and we said we'd come back to it, how do you encourage people to address all developmental areas? And I think the big key of this is, as we're looking at children for upcoming annual ASPs, and as we're looking through with everything, everyone is having to assess those children in all areas of development to prepare for that. And that we stop looking at things as these are the PT areas, these are the speech areas, and we start to think about it, these are this child's developmental delays, and these are the family's priorities.
Thank you, Tracy. That was really well said. I'm glad and that's a great parting message, I think, from this webinar. We did have another question from Southwest. What are you guys finding in terms of child progress using the PSP model? Any observations there that you've seen over time?
Oh gosh, I hate to answer that without having any real data. I mean, we are still data mining our child indicators, and I will say we don't have a great way of measuring how many outcomes have been met and that sort of thing. So I don't feel like I could safely answer one way or the other. What I can say, and again why I invited Tracy to participate, is that the providers are really feeling well supported in meeting the needs of the family. And we do know that research shows that if the provider has a good relationship with the family, the child's outcomes actually are better met than based on the education of the provider. So I think that's one of the reasons for moving towards this approach, is because it is a more relationship-based approach, and it's why we are moving towards using a coaching interaction style, which is another area that has lots of different myths. And I'd love to help with some of those doctors that feel like that they can't make the referral to ITC anymore because we're using a primary service approach or because we're using a coaching interaction style, because I think it's either that the myths are out there, or in some cases, I will be honest, what we found is that the myths become self-perpetuating in your own program. So I'll use a primary service provider for example, that you want to make sure your providers aren't afraid to ask for an increase in services or a second provider. You want to make sure that they know that you support those cases where children will need more than one provider. They still have a primary service provider. There's just another person on that plan that's helping them.
And Susan, I think that gets at the last question I'm going to take for today. I see we've got, because a couple people asked it, how are you making the primary service provider work with children with significant disabilities or multiple family priorities and concerns? And it looks like Kathy has helped answer that. She says those are the kiddos who often have more than one discipline serving their needs, but one is the primary. So I didn't know if you had anything to add to that. I mean, I think it ties into what you just said really nicely.
Kathy, that's exactly right. But I think Tracy would say as well that it depends on the skill of the provider. And if you have those providers that know when they are doing a good job of addressing it and know when to get support and their team is helping them. They might just have one provider in there for a period of time, but I will say one thing that we have found as a whole is that our IFSPs are more fluid, that we're changing them as they go along. Tracy, did you want to?
No, I agree with that wholly, and I think it's some of those families where there's just too much to work on. In some cases, we actually have increased those frequencies, so that child actually may get occupational therapy 6 times a month instead of 4 times a month by a family where the family needs that extra support to work on so many areas, but that therapist actually has the skills to cover it all because that family has a strong relationship with the primary provider.
Yeah. Well, ladies, I think we're going to wrap up because I see we're a little over on our time, but thank you, Tracy. I think that was well said. And Norfolk has offered some advice on that too by addressing families' biggest priorities first and then building the relationship. I think that's great. It's feeling like we might need another webinar on this topic. I don't know what you guys are thinking, but it looks like I'm seeing some comments in here. They want more on this, so we will certainly talk on that. I think we have so Robin says it's definitely a topic for helping folks update their practices and learn. So we are so delighted that people joined us today and you had so many great questions. I apologize if we missed them. They've been coming fast and furious. But if you have a question that didn't get answered today, feel free to email. You're welcome to email me and I'll pass it on to Susan and Tracy, or you can email them directly. We're happy to help support you all as you jump into using a primary service provider approach. So keep thinking about it, keep trying it, and we're happy to support you. We hope that you will join us in March for our next Talks on Tuesday webinar, and registration and information about that topic will be posted in the next few weeks. So thanks so much to Susan and Tracy, and I hope everybody has a wonderful rest of their day. Bye-bye.